Hello and welcome to this CME certified activity entitled Novel Approaches for Hormone Receptor Positive HER2 Negative Advanced Breast Cancer, Making Informed Clinical Decisions for Your Patients. This is part 2 of our program where we will focus on some data for the newer targeted therapies in ER-positive breast cancer. I'm Dr. Harold Burstein, a medical oncologist at Dana-Farber Cancer Institute and Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School. Thank you for joining us today. I have no real or apparent conflicts to disclose. This slide highlights some of the information available from Axis, our medical education vendor for this program. The goals today are to discuss the second-line management or how to overcome endocrine resistance. And to help that, at the end of our discussion, we'll have a clinical case to guide our treatment thinking. The learning objectives here include to interpret emerging and current clinical data on the efficacy and safety of treatment for ER-positive advanced breast cancer, to examine newer data and the rationale for therapeutic strategies aimed at overcoming endocrine resistance, and to discuss how to integrate some of the newer drugs that are coming along into our historical algorithms for management of advanced breast cancer. Well, one of the really important concepts that's emerging in management of ER-positive metastatic disease is the importance of understanding crosstalk between estrogen receptor and a variety of growth factor receptors and cell regulatory pathways, including the mTOR or rapamycin pathway. This cartoon figure from Steve Johnston, published a couple of years ago, makes the point that the estrogen receptor signaling cascade affects a variety of regulatory pathways within the cell, and there are interactions between all sorts of growth factor receptors, such as the IGFR and EGFR and HER2 signaling pathway, through the PI3 kinase pathway and AKT and mTOR pathways into the nucleus that clearly affect the activity of ER and provide opportunities for clinical synergy between these two strategies. And this has been proven to be clinically relevant in the BOLERO-2 trial, a study of aromatase inhibitor therapy given with or without the mTOR inhibitor everolimus in women who had ER-positive metastatic breast cancer that had previously progressed on AI therapy. And in the BOLERO-2 study, as published several years ago by Jose Baselga in the New England Journal of Medicine, adding exemestane treatment to, adding everolimus treatment to exemestane improved progression-free survival from around 3 months to around 7 months, and also improved the response rate. And so this really established the proof of principle that mTOR inhibition could be important in overcoming endocrine resistance for women previously treated with AI therapy. Now, as we've used this drug in the clinic, we've learned that it clearly has side effects, and that's a challenge for patient management. These data from a secondary analysis of the BOLERO-2 study show that there are high rates of stomatitis on the order of 30 to 40%, as well as hyperglycemia and pneumonitis that can be associated with everolimus therapy. And one of the key clinical pearls here is that the stomatitis can be very abrupt in onset. It typically arises within the first couple of weeks of therapy. And so when you send a patient out on a prescription for everolimus, you need to alert them to this possible side effect. Subsequently, we saw data from the TAMRAD trial, which was a very similar study as BOLERO-2, but used tamoxifen as the anti-estrogen therapy given with or without everolimus, again in patients who had previously had AI therapy. And in this trial, while adding everolimus did not markedly improve the response rate, it did improve the likelihood of progression-free survival and even tended to favor overall survival as shown in these data. So two real proof-of-concept papers that mTOR inhibition can enhance the effectiveness of anti-estrogen strategies in women previously treated with an AI. And that, of course, led to FDA approval of this drug in 2012. Approved in combination with exemestane, and we've already discussed some of the major side effects with this product of treatment. Now, some other pathways also interact with estrogen receptor, and understanding interactions between them is becoming increasingly important as well. One of those pathways has been the cell regulatory pathway, the cyclin-dependent kinase 4-6 pathway. and several companies have been developing drugs to inhibit CDK4/6 activity. This preclinical slide is an analysis from Rich Finn at UCLA looking at a variety of breast cancer cell lines classified by their intrinsic subtype as either luminal or basaloid or HER2 positive, and palbociclib, CDK4/6 inhibitor, making the point that the cell lines where you see marked inhibition of activity with palbociclib are those that were luminal or in some instances HER2 positive. That's where you saw the really dramatic benefits for the CDK4/6 inhibitor in breast cancer cell lines. And by contrast, some of the cell lines that are more aggressively proliferative, are neither ER positive nor HER2 positive, are less sensitive to this assay. And this work set the stage for the randomized phase 2 trial called PALOMA-1, which was an analysis of letrozole versus letrozole plus palbociclib as first-line therapy for ER-positive metastatic breast cancer. And in this study, they showed a substantial improvement in progression-free survival, moving from a median of about 1 year out to about 20 months with first-line therapy when palbo was added to the AI. Interestingly, in a subset analysis, they tried to accrue a cohort of patients who either had tumors with cyclin D amplification or P16 loss, and the qualitative analysis was the same. Palbociclib helped those patients as it did the unselected cohort of patients. Now, all drugs have toxicities, and of course palbociclib does as well. And as we're using this drug more, we're finding out more about those side effects. Neutropenia is the major clinical side effect. About half the patients will develop grade 3 neutropenia. This is part of the on-target side effect of this drug. The drug inhibits maturation of neutrophils because of the inhibition of the cyclins. And usually with cessation of treatment after the 3 weeks on, 1 week off schedule, when you get to that 3-week landmark and you stop the drug, the neutrophil count recovers. Parenthetically, as we've been using this drug in patients who have been more heavily treated with chemotherapy and other drugs, we actually see that the toll on the bone marrow can be a little bigger, I think, than some of the original reports might have suggested. We also see anemia and in some instances thrombocytopenia. There can be an increased risk of some degree of alopecia with the drug, though it's rarely huge alopecia. It's not chemotherapy type alopecia. And there are a variety of other side effects, including more fatigue and some upper GI issues with nausea that also characterize side effects of palbociclib. So in general, a well-tolerated drug, and fortunately, the incidence of complicated neutropenia with fever or with other stigmata of neutropenia is rather uncommon. Now, palbociclib was approved based on these randomized phase 2 data. Earlier this year, the FDA granted approval in first-line treatment of ER-positive metastatic breast cancer in combination with AI therapy, and of course noted the side effects that are encountered. What we learned this past year at ASCO is that second-line therapy with anti-estrogens may also benefit from use of palbociclib. And these were the results of the so-called PALOMA-3 study published by Nick Turner in the New England Journal of Medicine this summer. This was a second-line trial of patients who had had prior therapy with endocrine treatment for ER-positive metastatic breast cancer and who were randomized to either fulvestrant alone or to fulvestrant plus palbociclib. And in the PALOMA-3 trial, they reported an improvement in progression-free survival from around 4 months to around 9 months, a highly statistically significant finding in the second-line setting. So you'll notice, of course, the clinical point that first-line treatment, actually the results of first-line endocrine therapy are, in general, get much longer periods of tumor control than second-line. The 4-month or 3 to 4 month PFS with fulvestrant here, very consistent with the existing literature and improved by palbociclib. So there are other studies that are ongoing now to look at the safety of palbociclib and its efficacy in management of ER-positive disease. The PEARL study is comparing the palbociclib with exemestane versus capecitabine, so a very interesting design to compare chemotherapy choice versus an endocrine-based choice. A very similar study to this has been done in everolimus, and we're waiting for the results of that. And we are also waiting for the phase 3 study of letrozole plus or minus palbociclib in the first-line setting, the so-called Paloma 3 study, which will hopefully be available before too long. Now, there are other options that are also being explored for ER-positive metastatic breast cancer. Recently, we saw the data from CALGB 40503, which was a multicenter randomized trial led by Maura Dickler at Memorial Sloan Kettering, comparing letrozole alone versus letrozole plus bevacizumab. And Dr. Dickler presented these data again at ASCO this summer, showing that adding bevacizumab modestly improved progression-free survival from around 16 months out to 20 months with a p-value that was statistically significant. Unfortunately, the clinical impact of these data is probably going to be negligible because at this point, the world has sort of moved on from bevacizumab. There have been a lot of trials over the years that have shown that bevacizumab has improved PFS in advanced breast cancer without translating to improvements in overall survival and with greater toxicity. So I don't think it's likely that that product will move forward for endocrine treatment, but it is interesting that the same trends are seen in endocrine therapy combination with bevacizumab as they were in metastatic therapy for chemotherapy for a bevacizumab-based treatment. Another series of clinical trials is analyzing some newer selective estrogen receptor degraders, or SERDs. And in part one of our discussion today, we talked extensively about fulvestrant and issues of optimizing its dosing and discussing whether to use it in combination with AI therapy for metastatic disease. Now, fulvestrant's been around for quite a while, and there have always been some concerns about the pharmacology of the drug in the sense that the depot injection for a long time was thought not to be the best way ultimately of giving an estrogen receptor degrader. So there are several so-called SERDs in development. Several of these are orally available drugs, and these are clinical trials that certainly bear watching because it seems quite likely that they will be eventually getting to the clinical market. And one of the exciting things is that some of the studies looking at these SERDs are going to be focusing on the cohort of patients who have those acquired estrogen receptor mutations, which are activating mutations. Those are situations where AI therapy or tamoxifen therapy may not be effective because of the mutation, but where SERD therapy with fulvestrant or with some of these emerging drugs might be more effective. Another pathway where there's been tremendous clinical research looking at the interactions between the pathway and estrogen receptor signaling pathway has been the PI3 kinase pathway. And again, you may recall from the first discussion we had in this program that one of the most common mutations arising in about 30 to 40% of ER-positive breast cancers is a mutation in the PI3 kinase or mTOR-related pathways. So this has lent itself to the development of a number of clinical trials with multiple agents from multiple pharmaceutical companies, which are looking at the role of PI3 kinase in ER-positive breast cancer or in HER2-positive breast cancer. And this slide really gives you sort of a feel for the extent of this work. Now, there have been some challenges to the development of these clinical trials. Some of the PI3 kinase inhibitors are more selective than others. That is to say, there are multiple PI3 kinase isoforms, and some of these drugs are more selectively targeted to, say, the alpha isoform than others. It's been unclear whether that degree of selectivity is a major clinical advantage and more on target or not. And similarly, many of the trials have been accruing patients whose tumors do not have PI3 kinase mutations because it's been unclear whether the presence of a mutation is critical for seeing clinical activity or not. So it's actually taken a lot of work to sort out those key issues as to whether a more selective drug is better and to whether a tumor selection needs to be done beforehand to find patients who have mutations. This slide talks about pictolisib, which is one of the PI3 kinase inhibitors that's furthest along in development. There have been some recent studies looking at fulvestrant given with or without pictolisib, and there was a suggestion in a randomized phase 2 trial that there was a modest improvement in PFS for patients who were getting this agent in comparison to just endocrine therapy alone. And so confirmation of that is still pending in larger phase 3 trials. So the flavor we're trying to give you here is that after many decades of work in estrogen receptor targeted therapies using anti-estrogens, aromatase inhibitors, which work by estrogen deprivation, tamoxifen, older agents such as megestrol acetate or other progestins or even estrogens themselves. We're finally really shifting to an era when we are thinking about combining anti-estrogen therapies with other pathway-targeted drugs. And that includes success with the mTOR inhibitors in everolimus, success with the CDK4/6 inhibitors with palbociclib, and the feeling that we're going to have success also, though of course we don't know yet for sure, with PI3 kinase inhibition, now being piggybacked into our treatment algorithms for ER-positive metastatic breast cancer. So where do we stand? So in a typical algorithm for ER-positive second-line therapy after AI treatment would be either fulvestrant or, based on the PALOMA-3 data now, fulvestrant plus palbociclib. We don't know exactly how that would compare to more AI therapy paired with everolimus. I think either of those would be legitimate options. Obviously, the fulvestrant in injection versus the all-oral regimen of the aromatase inhibitor plus everolimus. Having said that, perhaps palbociclib with a slightly more favorable side effect profile, though again, these have not been compared head-to-head. In third line, we know less about the optimal regimen because now that we're using these newer drugs, the fulvestrants and the palbociclibs and the everolimus type agents in first or second line, it's unclear how our traditional data for third and fourth and so forth lines of therapy really play out. But this would be the opportunity to introduce palbociclib if not already done, or everolimus if not already done, or tamoxifen if not already done. And again, in patients who have indolent disease or don't need chemotherapy yet, opportunities to continue to look at things like progestins or estrogens. And ultimately, at some point, many of these patients will need chemotherapy. And I think one of the exciting developments is that we're now seeing in the modern era this question, can we use better anti-estrogen combinations versus chemo? And those clinical trial results are eagerly anticipated. So let's close our discussion of Chapter 2 here by again looking at a case of second-line therapy for ER-positive breast cancer. This is a woman who is 57 years old and 4 years ago was diagnosed with stage 2 breast cancer. Her tumor was a little over 3 centimeters in size, high grade and node negative. It was ER positive, PR low positive, and HER2 negative. She received breast conserving surgery and then docetaxel cyclophosphamide chemotherapy for 4 cycles, radiation therapy, and 4 years of endocrine therapy with an AI. Then she was evaluated for nonspecific symptoms that included fatigue and again was found to have bone lesions. A CAT scan also demonstrated a focal abnormality in the liver as well as her bone metastases. And a liver biopsy showed ER-positive metastatic breast cancer, PR low positive, and HER2 negative at this juncture. And here's an example of the kind of thing we see. Most people would think of this as a so-called luminal B type breast cancer, that is ER positive but having lower levels of PR and having higher grade than a luminal A breast cancer, which would more typically be both ER positive, PR positive, and lower grade overall. So how would we think about this patient? She's progressed or developed metastatic disease while on AI therapy. So she has some primary resistance to endocrine treatment by definition. So your treatment options could include fulvestrant with palbociclib, switching AIs to letrozole plus palbociclib, or switching AIs to exemestane plus everolimus. And we don't have compelling data to tell us which of these strategies would be best. In my own practice, based on the PALOMA-3 data, I would probably give fulvestrant plus palbociclib in this instance, a patient progressing already on an AI, and hopefully would get benefit from one of these targeted therapies in the second-line setting. So that concludes Chapter 2 of our program on novel approaches for hormone receptor positive, HER2 negative advanced breast cancer, making informed clinical decisions for your patients, this section focusing on second-line therapy. Thank you very much for joining us today.